This is The Rounds Table. All right, welcome back, Rounds Table listeners. This is by far usually the most popular episode of the year, and this is where we cover the top 5 articles of the past year. We're recording this December 2nd, 2025. And yeah, let's just jump in. So I have the first article. It is entitled Apixaban for Extended Treatment of Provoked Venous Thromboembolism. The short form is the HI-PRO trial. And the research question here is whether or not for adults with provoked VTE who've been treated for 3 months, but they have one enduring risk factor, should they receive an additional low-dose Apixaban for 12 months to reduce the risk of symptomatic recurrent VTE?
All right. And so how do they do this study?
So this was a placebo-controlled, industry-funded study. As mentioned, the primary outcome was first symptomatic recurrent VTE. In the subsequent year, it was a double-blind trial. It was just conducted at one center, which is definitely an important limitation. And the included patients, as mentioned, had a provoked venous thromboembolism. They had already completed 3 months of treatment, but they had at least one enduring risk factor. The main buckets of enduring risk factors could include they had an inflammatory disease, think lupus. They had a chronic lung disease, think COPD, or they had a BMI greater than 30. They were randomized to Apixaban 2.5 milligrams twice a day, so that's the lower dose. And the comparator group was placebo, and they analyzed the data using intention to treat. And I don't know if I already mentioned it, and if I did, I'll mention it again. It was a double-blind trial.
Okay, cool. So what did the patient population look like?
So they randomized 600 patients in total. The typical patient was a 60-year-old Caucasian woman. Half had an isolated venous thromboembolism, like a deep vein thrombosis, I should say. The most common provoking factor at the time of that venous thromboembolism was surgery or trauma. And the most common enduring risk factors that the patients had, so half had a chronic inflammatory condition and half had a BMI above 30.
All right. So what did they find?
So for that primary outcome of recurrent and symptomatic VTE in the subsequent year, there was a marked lower rate with Apixaban compared to placebo. The hazard ratio was 0.13 with confidence intervals of 0.04 to 0.36. It's very, very rare to see a hazard ratio that low in a randomized trial. I don't actually know if I've ever seen one that low before. A couple other relevant endpoints. So there was no increased risk of major bleeding between the two groups. There was likely a higher risk of clinically relevant non-major bleeding, wide confidence intervals, but clearly an increased risk. And we're talking, close to 5% with Apixaban compared to closer to 1% with placebo.
Okay, so what are some of the limitations here?
So, a single center trial is problematic, not just for external generalizability, but there have been many examples of past large randomized trials that have only been done at a single center. And then when you do a multi-center study, you find a null effect or sometimes an opposite effect. And then also just a pretty small sample size at 600 some odd patients.
Yeah, okay, that's fair. So what's the takeaway here?
For patients with provoked VTE who've completed 3 months of treatment, there might be a subset who stand to benefit from an additional 12 months of low-dose Apixaban.
Yeah, and why did this make your top 5?
Yeah, so top 5, it made it in that because VTE is relatively common among our patients. And I think these data are thought-provoking because they challenge the current paradigm. And I feel like the current paradigm is that, hey, if you have a provoked venous thromboembolism, you get 3 to 6 months, and then we stop treatment.
Yeah, I like this paper a lot. And maybe we just need to replicate the data in more than one center, but otherwise it's pretty compelling.
Yeah, totally agree. All right, 1 down, 4 to go. John, what do you have up for us next?
So next, it is Tirzepatide for heart failure with preserved ejection fraction and obesity. This was from January 2025, published in the New England Journal of Medicine by Packer et al.
And research question?
The question here was, what is the effect of Tirzepatide on worsening heart failure events, health status, and functional capacity in patients with obesity and heart failure with preserved ejection fraction?
Yeah, there aren't many treatments for heart failure with preserved ejection fraction, so the impetus makes sense to me. How do they design the study?
Yeah, bingo. So this was an industry-funded, placebo-controlled, double-blinded, multi-center RCT. The patient population, it was men and women 40 years of age and older with NYHA class 2 to 4 heart failure, an LVEF of at least 50%, and a BMI of at least 30. There were a few specific criteria that needed to be met based on some BNP cutoffs, left atrial enlargement, and elevated filling pressures. They also had to have at least one heart failure decompensation event within 12 months before baseline or a GFR of less than 30. So for the intervention, patients were randomly assigned 1-to-1 to either Tirzepatide 2.5 milligrams per week or placebo in addition to usual care. Doses were increased 2.5 milligrams every 4 weeks to a max of 15 milligrams. So for the outcomes, during the trial, the primary outcome was amended, and this was due to data from the Semaglutide trial in patients with obesity and CHF. The investigators and sponsors did not have any knowledge of the unblinded data, and this was done before the Data and Safety Monitoring Committee had conducted any efficacy analyses. So the two primary endpoints changed to 1, a composite of adjudicated death from cardiovascular causes or worsening heart failure events, and 2, change in a quality of life metric at 52 weeks. And this was an intention to treat analysis.
Okay, and what did the included patients look like?
So about 1,500 patients were screened and 731 were randomly assigned to either Tirzepatide or placebo at 129 centers in 9 countries. The average age was 65, 54% were women, the mean BMI was 38, 72% were NYHA class 2, the rest were class 3 or 4. And then 80% were on renin-angiotensin systems or neprilysin inhibitors at baseline, 67% on beta blockers, 35% on mineralocorticoid receptor antagonists, about 17% on SGLT2 inhibitors. And the median follow-up here was 2 years.
Okay, and what did they find?
So for the primary outcome number 1, which was death from cardiovascular causes or worsening heart failure events, this occurred in 9.9% of patients in the Tirzepatide group, compared with 15.3% in the placebo group. This corresponded to a statistically significant hazard ratio of 0.62 with confidence intervals from 0.41 to 0.95. The absolute risk reduction here was 5.4%. For the second primary outcome, this was the change in quality of life metric. The mean increase was 19.5 points in the Tirzepatide group versus 12.7 points in the placebo group. For the composite of worsening heart failure events, this seemed to be largely driven by a reduction in hospitalization with almost a 4% absolute risk reduction, as well as reduction in IV diuretic therapy, which was about a 2% absolute reduction.
Okay, so, pretty impressive findings and, a very impressive absolute risk reduction. What were the main limitations?
So I guess it doesn't provide insight into our overweight patient population. It's only those with a BMI of over 30. And then it was a composite of a composite. The worsening heart failure event included hospitalization, IV therapy in an urgent care setting, or intensification of oral diuretic therapy. And I guess the question comes down to whether you think changing an oral diuretic dose has the same clinical significance as being hospitalized for heart failure, but somewhat reassuringly, it didn't seem that was what was driving the composite.
Okay, fair enough. And take-home point?
In patients with a BMI over 30 and heart failure with preserved ejection fraction, Tirzepatide reduced the risk of a composite of worsening heart failure events or death from cardiovascular causes and improved health status in those patients.
Yeah, and why did this make your top 5?
I mean, really, because you said it right up front, we don't have a lot of goal-directed medical therapy for heart failure with preserved ejection fraction. So this drug, really becomes a big game changer for those patients.
Yeah, I think the really challenging aspect, at least in Ontario, is that Tirzepatide is hard to get access to because it is so expensive. But what's the access like? Have you seen it commonly being given in Alberta, for example?
No, I think it's the same thing. It's like if your private insurance is going to cover it, we still have a hard time getting Ozempic for any of its other major indications unless you have diabetes and obesity. So as with a lot of things, it takes far too long for these drugs to finally get on the formulary.
Yeah, I agree. And at least with Ozempic, Wegovy, Semaglutide, the patent runs out in Canada in 4 weeks. So I think this spring and summer, there's at least 7 generic drug makers that are chomping at the bit and ready to, start getting access to the Canadian market. And hopefully that'll reduce the price of Semaglutide. All right, the next article we'll discuss is aspirin in patients with chronic coronary syndrome receiving oral anticoagulation, published in the New England Journal of Medicine, and it was the AQUATIC trial. And the research question here was for patients with a prior drug-eluting stent and at least 6 months the stent was placed prior, so not like a fresh stent, and the patient had an indication for an anticoagulant. most often AFib. They wanted to understand whether or not aspirin, in addition to the anticoagulant, was superior to placebo plus the anticoagulant.
Okay, cool. I like this idea a lot. How do they do this study?
So they included patients, as mentioned, who had a drug-eluting stent at least 6 months ago, and they had an indication for an anticoagulant. Again, most often that was atrial fibrillation. Patients were then randomized to the intervention, which would be aspirin 100 milligrams daily or placebo. The primary outcome was a composite of death from cardiovascular causes, heart attack, stroke, systemic embolism, coronary revascularization, or acute limb ischemia. A definite mouthful of a composite outcome, and I won't bury the lead. That's definitely one of the limitations of this study. But to their credit, it was double-blinded, so you would hope at least that adjudication wouldn't be differential, and they included patients from 51 centers internationally.
Okay. What was the baseline study characteristics?
So 872 patients were randomized. The typical patient was a 72-year-old man with diabetes, heart failure, CKD, and atrial fibrillation. And of course, they also had coronary disease, and that stent was placed typically more than 9 months prior to the time of randomization. Often it was like a year or more.
All right. What did they find?
So that primary outcome of death from cardiovascular causes, MI, stroke, systemic embolism, coronary revascularization, or acute limb ischemia, it actually occurred more often in the anticoagulant plus aspirin group compared to in the anticoagulant plus placebo group. So a hazard ratio of 1.53 with confidence intervals of 1.07 to 2.18. So that's bad. You don't want this cardiovascular endpoint to be occurring more often. And then they actually had to stop the trial early because they observed an increased risk of all-cause mortality in the aspirin group at approximately 13.5% compared to 8.4% with placebo. So, said differently, a 5% absolute increased risk of all-cause death. And then in case there was another nail that was needed in this coffin, they also observed a much higher risk of major bleeding, and that was 10% with aspirin compared to closer to 3% with placebo.
Oh, geez. Those are all pretty big deal. Before we dig into it, what were some of the limitations here?
So, a bit of a messy composite outcome. The trial was stopped early, and when trials are stopped early, it's just important to identify whether or not these results are robust. But I think they definitely are, because it turns out there have been 3 other randomized trials in this space. They go by the acronyms AFIRE, Apixaban, OAC alone, and all of these trials had a very similar design whereby they had a patient who had AFib and coronary disease, and they were trying to answer the question, is an anticoagulant by itself sufficient, or should we be adding aspirin? So taken together, the overwhelming evidence and data would suggest that the results from this trial probably reflect truth.
All right. What's kind of the one-liner from the study?
So the combination of aspirin plus an anticoagulant increases all-cause mortality, increases cardiovascular events, and increases bleeding in patients who've had a drug-eluting stent placed at least 6 months prior, and they have an indication for an anticoagulant.
All right. Why did it make your top 5?
So, AFib, coronary disease, that is so common among the patients we care for in the inpatient setting. And prescribing inertia is such a powerful force. It's so busy on the wards. I completely get it. But because it's so busy, inertia just carries whatever medications this patient was on before they came into hospital. And I think these are great data to show that for those patients, we should, put our foot on the brakes and deprescribe aspirin. Continuing aspirin clearly is putting patients at increased risk of harm.
Oh, I totally agree. I've been prescribing inertia is so real. I find that we're very lucky where I am in Calgary. We have some excellent pharmacists who really pick up on some of these kind of details and be like, hey, should we chat about their aspirin? Do they still need it? And this trial will be a great one to quote as we're then sort of making some decisions.
Yeah, I completely agree. I think we'd be lost without our inpatient pharmacists. And I think there's the behavioral psychology of it all in that if you do nothing, the drug continues. So it's easier for the drug to just continue. You have to exert energy to realize, oh, it's there. Why is it there? Oh, the drug-eluting stent was 9 years ago, for example. Anyway, end of rant. Okay, John, what trial do you have up for us next?
So this is the liberal intake versus restrictive fluid intake in chronic heart failure, a randomized control trial published in Nature Medicine, March 30th, 2025 by Herman et al.
Okay, and what was the research question?
They wanted to know what are the effects of a liberal versus restrictive fluid regimen in patients with chronic heart failure in the outpatient setting.
Yeah, I mean, I really loved this trial because it just answers such an important pragmatic question, because we fluid restrict patients with heart failure, but not based on good data, and I'm sure patients hate it. Anyway, what was the study design?
So this was an investigator-initiated, multi-center, open-label, randomized control trial done in the Netherlands. The patient population, they were patients with chronic heart failure for more than 6 months who had NYHA class 2 or 3 symptoms. They included both reduced and preserved EF. For some of the key exclusion criteria, so if you were hospitalized 3 months before randomization, if you had a permanent pacemaker, any changes in your heart failure meds 14 days before randomization, a GFR of less than 30, or a sodium of less than 130. For the intervention, patients were randomized 1-to-1 to liberal fluid intake versus restrictive. For the liberal fluid intake group, this was defined as fluid intake as desired without a maximum. For the restrictive group, it was up to 1,500 mils per day. For the outcomes, the primary outcome was the KCCQ quality of life measure at 3 months. On this metric, a 5-point change is considered small but clinically important. They also looked at safety outcomes, including a composite of death, hospitalization, and IV loop diuretic treatment.
Cool. And what did the included patients look like?
So 500 patients were randomly assigned to liberal fluid intake or fluid restriction. The average age was 69, 67% were male, 87% had NYHA class 2 symptoms. Half of patients had a reduced EF, and about half had been doing some form of fluid restriction before study participation.
Okay, and what did they find?
Well, what they found was the quality of life measure at 3 months was 74 in the liberal fluid intake group and 72.2 in the fluid restriction group. That was a mean difference of 2.17. That was not statistically significant, with confidence intervals ranging from negative 0.06 to 4.39. Perceived thirst distress was significantly lower in patients randomized to the liberal fluid intake group, with a mean difference of 2.29 points, and there was no difference in the safety outcomes.
Oh man, yeah, what a humbling result. Okay, what are the limitations?
Not so much limitations of the study itself, but more considering the generalizability, I guess. But these results do not translate to those with unstable heart failure with recent hospitalization, those with hyponatremia, and of course, this was a smaller study design with a short follow-up window.
Gotcha. Take home point.
Liberal fluid intake appears safe for patients with stable congestive heart failure.
Okay, and why did it make your top 5?
Well, I think it's really nice what the research set out to do to challenge the dogma that exists in medicine. So kudos to them. And this could make a big change for patients' quality of life.
Yeah, totally agree. All right, and the last trial up for us is phase 3 trial of Semaglutide in metabolic dysfunction-associated steatohepatitis, the ESSENCE study, published in the New England Journal of Medicine. And the research question here was, among adults with obesity and biopsy-confirmed MASH and liver fibrosis of stage F2 or F3, which is moderate to advanced, did semaglutide improve the resolution of steatohepatitis compared to placebo?
I like this study a lot. What was the design here?
I totally agree. I mean, what a great study. You know, we have this condition that's so common, and until recently, there were really no treatments for it whatsoever. So as mentioned, everyone had to have a biopsy in order to make it into the study, and that allowed them to have some diagnostic certainty that they indeed had MASH, and they had at least moderate, if not advanced fibrosis. The included patients were randomized to once weekly semaglutide, 2.4 milligrams with dose escalation as needed, or a matching placebo. The primary outcome, actually, there were 2 primary outcomes, which is always kind of bizarre, but these included 1, resolution of steatohepatitis with no worsening of fibrosis by week 72, and the other primary outcome was reduction in liver fibrosis by at least 1 stage with no worsening. The study itself was funded by Novo Nordisk. That primary outcome, just to hammer it home, was repeat biopsy. So everyone needed 2 biopsies if you were in this study. It was a double-blind trial and conducted at over 250 centers internationally.
All right. What were some of the baseline characteristics?
So they randomized just under 1,200 patients. The typical patient was a 56-year-old Caucasian woman with a BMI of 35, type 2 diabetes, and most had advanced fibrosis seen on their liver biopsy.
And what did they find?
So those two primary outcomes, the first one was resolution of steatohepatitis. That occurred in 63% with semaglutide compared to 34% with placebo. So like a 29% absolute improvement with semaglutide. The other primary outcome of reduction in liver fibrosis was observed in 37% with semaglutide and 22% with placebo. So, a 15% absolute improvement with semaglutide. A few relevant secondary outcomes. So, systolic blood pressure was lower in the semaglutide group by 4 millimeters of mercury. A1C dropped in the semaglutide group by 0.5%. Serious adverse events occurred in 13% with semaglutide and 13% with placebo, but GI side effects were more common with semaglutide.
All right, what were some of the limitations here?
The primary outcome being a liver biopsy, that gives you a lot of certainty, but it just feels like patients aren't asking us, hey doc, can you repeat the biopsy on me and see how things look? It's just, I feel like it's not the most patient-centered outcome, and we're still awaiting the clinical outcomes. So I think what we really want to know is not just, does the liver histology look better, but instead, do patients feel better? Do they have less decompensated cirrhosis, etc.? Also, it was, of course, an industry-funded trial. And then finally, I should mention that although I'm harping on them for that primary outcome of repeat liver biopsy, it's actually not their fault. This is what the FDA requires if you are trying to put forward a potential treatment for MASH.
All right, what's the takeaway message?
Among adults with MASH and moderate or advanced fibrosis, once-weekly semaglutide improved liver fibrosis.
Why top 5? I mean, there needs no explanation, but what did you think?
Yeah, MASH is so common. I feel like on the typical internal medicine ward, probably at least 25% of patients have it. I think many have it, and it's never been diagnosed. And so many patients who have MASH also have diabetes or obesity. Sometimes they have all three together. And I think there's still a pretty large gap between, we have these great drugs that are available to treat things like obesity, diabetes, and now MASH, between practice. So that's why I think it made the top 5 for me.
Yeah, I totally agree. Maybe just to pick your brain too. So you had mentioned earlier that the patent is getting old for Ozempic, but how does that apply when it's a new indication for the drug? Does the original patent still stand, or will the generics be available for something like MASH, for example?
Yeah, good question. It gets complex pretty quickly. So the patent is running out in Canada, but in the US, it's not running out. So I mention that because within a given jurisdiction, the rules can be different. When the generics become available in Canada, they will be for the first indication of semaglutide, which would have been diabetes. So technically speaking, and listeners can correct me if I'm wrong, there won't be a generic for, say, Wegovy, the obesity formulation of semaglutide, come the new year in Canada. But I think everyone knows that, all right, well, I'm just going to prescribe you the semaglutide version, and now that it's generic, save you hundreds of bucks, and we can up-titrate the dose. Maybe not as high as we would get with Wegovy, but, high enough to make sure you're seeing some pretty impressive benefits.
Yeah, okay, that makes sense.
Well, that's it for the top 5 of 2025. Before we end, good stuff. What do you have on your end, John?
Well, 'tis the season. Pick a charity, maybe pick 2, and try to donate some money if you can. My personal go-tos are the Toronto Star Santa Claus Fund and the Calgary Food Bank.
Yeah, I like that. Britt and I just donated to War Amps, which is, just a great charity. And when you donate to War Amps, they give you a little tag for your keychain, and that tag doesn't say your address on it, but it has a unique number. So if you ever lose your keys, somebody can drop them off to any mailbox, and your keys will get back to you. So I like that. And then they also give you these little stickers that you can put on envelopes that have your name and address and all that good stuff. So in case you need another reason to donate to the War Amps.
Oh, that's great. I like the key tag thing a lot.
All right, John, that is it for 2025. Stay well. I'll see you in the new year. Actually, no, I'll see you in a few weeks for the holidays. But when this comes out, I might not have seen you yet.
Yeah, we'll see you at Mom and Dad's.
Yeah, exactly.
Merry Christmas. Happy New Year's to our listeners.
All right. Take care, John.
See ya. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.